Thank you, everybody, for coming to our April meeting of the Nebraska Radiology Society. It's my pleasure to introduce everyone to our speaker tonight, which is Dr. Cox. He's been a fine addition to our division at the University of Creighton. He's a thoracic radiologist and the chair of the Department of Radiology at Creighton University School of Medicine. Primary area for clinical interest and research revolves around chronic lung disease, particularly connective tissue disease, interstitial lung disease. After completing residency at Creighton University in 2007, served 4 years as a diagnostic radiologist for the U.S. Army, and subsequently completed a fellowship at the Cardiothoracic Imaging at National Jewish Hospital Health at Denver, Colorado, and currently works at the Creighton. He worked as a staff at the National Jewish Health and Mayo Clinic before accepting his current position at Creighton, and he's here to talk to us today about connective tissue disease and pulmonary manifestations of connective tissue disease. So thank you, everyone, for thank you so much.
Bear with me here. Get this set up. All right, so it is always an honor to be invited to speak, but to be invited by friends and professionals that I have the utmost respect for. It is a great honor to get to speak today. So thank you very much for the invitation. I'm going to be talking about autoimmune disease and the pulmonary manifestations of it. All right, so first, kind of focusing primarily on the work that I've done so that it's coming from a place of experience. We're going to look at signs associated with CTD-ILD, diffuse pulmonary ossification in terms of differentiating types of interstitial lung disease, recognizing combined NSIP-OP as a unique pattern that helps you categorize and differentiate types of ILD. Talk a little bit about IPAF, interstitial pneumonia with autoimmune features, as sort of a newer category and why it's important. And then briefly at the very end, because I know we all have a fair amount of experience with COVID and post-COVID if you're reading chest x-rays or chest CT, and what the kind of literature and is saying about it, as well as how it relates to the picture of CTD-ILD. No disclosures. I will say that I had the pleasure of going to the SDR meeting last month in Charleston, South Carolina. Just absolutely beautiful. But I gave a talk, well, I went to a talk there that focused on sort of this material. And what I was kind of struck by was the fact that they were showing these images of signs, and I was thinking those are not good examples of these signs. And then going into the literature, so if you're familiar with interstitial lung disease and categorizing fibrosis, these are probably two articles that you should be familiar with. First is 2018, and that's the ATS criteria that first set up how do you kind of categorize UIP, probable UIP, indeterminate, and suggestive of an alternative diagnosis. And then just last year, they came out with a more recent one looking at progressive fibrosis, but also discussing some of the new findings in the literature related to IPF. So an update to that. Why is this important? So the first you might say, well, we have these antifibrotics now, and the antifibrotics have been shown to be useful in IPF, they've been shown to be useful in connective tissue disease, they've been shown to be useful in hypersensitivity pneumonitis. So who cares? Let's just, and once we see fibrosis, why don't we treat it? And there are three primary reasons. One being that it's been proven for a long time that if you have an autoimmune disease, interstitial lung disease, that you treat with immunosuppression, they do better. They live longer, they have better life. The Panther study that I'm showing you here kind of is the flip to that. So what they did was they took IPF patients and then gave them prednisone, azathioprine, and N-acetylcysteine versus placebo. And what they found out was in those IPF patients that they treated with immunosuppression, they lived shorter lives and had more hospitalizations. So you don't want to give treatment, immunosuppressive treatment to IPF patients. You do want to give it to the connective tissue diseases. And for the connective tissue diseases, they also have a better prognosis. So the problem is when someone hears, oh, UIP or IPF, they get on the internet and they see that its life expectancy is equivalent to lung cancer. It's 20% survival rate at 5 years, comparable to lung cancer. That's been a little bit better but with the antifibrotics, but IPF is not a good diagnosis to get, right? And if you can recognize that they have features of an autoimmune disease, that's better for the patient off the bat. So looking at these two ATS criteria, the first one being 2018, which is what I'm showing you here, which probably most of you, if you've worked with this, or you're familiar with it. And basically, this is the classic UIP. This is the basilar predominant gradient fibrosis with honeycombing, right? Probable is they don't have the honeycombing, but they still have that basilar predominant fibrosis. Indeterminate means that whether it's kind of a pattern that is uniform or patchy in its craniocaudal dimension or its axial dimension, but it's just you look at it and you think, this doesn't look like anything to me, right? And that's the one that you put into that indeterminate category. And then alternative diagnosis, which this is not a good name. The Fleischner Society actually put out similar kind of chart in 2017, and I like it more. But this one is the one that I think has taken hold most firmly. And the reason I don't like it is alternative diagnosis, this breakdown is actually for UIP, right? And UIP is not a cause, right? It's not an etiology. It's just a histologic finding, histopathologic finding. So calling this alternative diagnosis, well, I can have UIP and have an alternative diagnosis to IPF, and this article is specifically talking about IPF, right? So this column name is not good. But in it, what you really take away from it is that it does have features that are an alternative diagnosis, whether that's cysts or nodules or an upper lung predominance or whatever it is. Okay? So this is the 2018 one. They updated it. Jonathan Chung actually did a very nice study that kind of helped define these numbers for us. But I will say that this number is low. His numbers were more like 85 to 90% if you had a probable UIP pattern. And why is that important? Because what we're really trying to do is differentiate who should get biopsy and who shouldn't, right? Because what this is saying is if you're in these two columns, there is a 90% likelihood that you have UIP, and if you biopsy them, you're just going to see UIP on the biopsy. And in those patients, if you biopsy them, they do worse, right? So we're trying to avoid biopsy in these patients, and this allows us to do so. And so these two categories are more the ones that you're going to work in terms of multidisciplinary conference, but it has created, it's made our jobs a little bit tougher in the world of ILD because, now these people are pretty familiar with them and nobody's needing to discuss these anymore, and now all the cases are tough. So that makes it a little bit of a challenge. But again, they kept this alternative diagnosis, which is misleading in the fact that, again, you can have a UIP pattern that is rheumatoid arthritis or scleroderma or any of the autoimmune diseases, or even sarcoid for that matter. And why we created our signs was that we recognized that we could put them in this column, but we knew they weren't IPF, like just by looking at it. And so that's why we kind of began to study these signs. The other thing that I'll mention here is the pulmonary ossification. So this pulmonary ossification, I'll talk more about what that is and why it's important or not important. But in this, it's implying that it has some sort of differentiating characteristic for a UIP pattern. So this is from the 2022 article for the ATS. And they show this as a UIP pattern with CTD-ILD, or UIP, in a patient with dermatomyositis and scleroderma. The challenge for me is that I wouldn't even put this in the UIP pattern, because I can tell, like, the honeycombing is bunched around the bronchovascular bundles, and it's actually a little bit better out in the periphery. And that's more a characteristic of connective tissue disease or autoimmune disease. I'll use those interchangeably, but when I say connective tissue disease, the reason I would say autoimmune disease is because CTD also includes stuff, that are like Ehlers-Danlos and those things, where I'm really talking about specific autoimmune disease. But they talk about this as an anterior lung sign of CTD-ILD. That's true. But then they also talk about this as exuberant honeycombing, and I'll talk about all these definitions, which is also true. But again, I wouldn't have had a problem with this case because I wouldn't have even called it UIP to begin with. Then they show this as the example in the ATS article as a classic UIP pattern of honeycombing. But I can tell you that this is not IPF, even though this article is specifically trying to show you an example of IPF. This patient has a connective tissue disease. They have exuberant honeycombing. They have well-defined margins of their fibrosis. The lung that isn't involved looks pristine. This is classic look for probably rheumatoid arthritis or scleroderma. So I just wanted to show an example of what really a UIP IPF should look like. So this is going to play, but then I'm going to have to do it here so it's not too fast. But you'll notice there is the basilar gradient, but as I come through the lung, you'll see that there's fibrosis that's involved in a fair amount of the lung before I get down to the bases. And then in the bases is actually where I have honeycombing. And so the honeycombing is actually a very small portion of the overall fibrosis. If I look at that on a coronal image, again, look at how much fibrosis I actually have throughout all of this lung. I would say about 70% of the lung is involved in fibrosis, but I only have honeycombing in a very small portion in the costophrenic angles. Right? And then if I look at their chest x-ray, even from the chest x-ray, I would look at this and I would say, this is an IPF pattern of fibrosis. Low lung volumes. I've got a lot of volume loss associated with this coarse reticulation. Right? So this is what IPF looks like. It does not look like the image that they show in the article as a classic example. So my take-home lessons from all that is, one, the CTD-ILD patterns are not well understood. And their usefulness for the patient is really in the subgroup of applying it appropriately. The second is that the 2022 ATS update, despite showing the images and talking about it, doesn't actually include it in the table. So if you were just going to have a link on your workstation and you were just going to pull up the table and say, okay, based on this criteria, I'm going to put it in this. You wouldn't even consider the CTD-ILD signs. And then finally, the fact that they continue to use these categories that are not mutually exclusive as far as saying something is an alternative diagnosis. So what are these signs? Exuberant honeycombing sign. This is just saying that the majority, 70% of the fibrosis is involved in honeycombing. But I will tell you that there are other features of this that we're beginning to look at as well. One is the fast transition between involved lung and uninvolved lung, like that very clearly defined transition. Although people say that's the straight edge sign, that's not the straight edge sign. It's something that we haven't really looked at, and it would be a good study unto itself. But the other is that, and one that I'm just starting right now, is that exuberant honeycombing holds its volume. So I'll show you some examples, and the lungs won't be collapsing down despite they have really profound interstitial lung disease. The second is a straight edge sign. This was actually a sign that was pointed out by Jeff Swigris at National Jewish, and he called it the pancake sign. And the reason that it gets misapplied is because of that quick transition, but what we're really talking about is this very profound basilar predominance of fibrosis that has this straight edge to it on coronal. So it's just this very well-defined normal lung, boom, involved lung, collapse. So they're going to have very low lung volumes, and it's just going to collapse down. And we just happen to notice that it also produces a very straight edge. And by using all of these signs, we could show that they had significant differentiating features between IPF and the CTD-ILDs. Next is the anterior lung sign, and that is focal fibrosis in the anterolateral upper lobes. So when IPF first started getting described as a UIP pattern, Nadich described this propeller sign. And it's basically, as you scroll through, you notice that the fibrosis kind of does this. If you scroll fast, really fast, it does this kind of spin around the peripheries. And that is different. We were needing to differentiate that from the anterior lung sign, which is a discontinuous fibrosis just in the anterior lungs. And when you see it there, very high association. But then it was really born out of the recognizing this thing that I called for a long time, four corner sign, which is the anterolateral upper lungs, but then also recognizing that if they had isolated involvement of the superior segments of the lower lobes, I called it the four corners. It just looked like four corners to me. I'll show you and you can decide if that's true. But when we did this study, we used IPF and scleroderma, because scleroderma was where we saw it the most. And so if two thoracic radiologists agreed that there was the four corner sign, 100% scleroderma versus, and then, there were a fair amount of scleroderma patients that didn't have it that would not be differentiated by it. But if they had it, it was uniformly scleroderma. So what's the exuberant honeycombing sign? This was actually a case that I had just 2 weeks ago. And this is a 39-year-old with systemic lupus erythematosus, SLE. And the reason I really like it for an example is it is almost a photographic copy of what they used in the ATS article. So I have very profound fibrosis. I mean, you wouldn't really be thinking IPF because they're a 39-year-old anyway, so you'd be thinking a connective tissue disease to start out with. But this patient is just absolutely classic example. I would say the vast majority of their fibrosis is honeycombing, right? These cystic, stacked cysts on the periphery of the lung with associated volume loss. So that's honeycombing. Sorry. And I've always I've been a little bit wary of using the word beautiful to describe these things, but I want to. Like, I see it and I say, that's a beautiful pattern of honeycombing. And, you know, describing the disease, imaging, you know, is that really a fair thing to say? And then I came across some of James Joyce, where he describes beautiful in these three characteristics: wholeness, harmony, and radiance, right? So the wholeness of it is all that thing. All the pieces of it have harmony within it. And then there's radiance in form. So it's kind of this idea of it's reaching its perfection of form. And in that, I think that's what we're seeing. We're seeing this beautiful pattern because all you see is this very harmonious, whole perfection of its appearance, right? And so just to compare what you're seeing on the exam that we just looked at, right? So this is the patient we just looked at, and this is their example in ATS of a UIP pattern for IPF. And this is probably a little bit of their anterior lung sign that they cut out. Straight edge sign. So this is another patient, they have antisynthetase syndrome. And one thing that I'll say, and this goes along also with the NSIPOP combination, is these things probably would have been appreciated a long time ago, but we didn't recognize antisynthetase syndrome. And it's in the myositis group, right? So antisynthetase, dermatomyositis, polymyositis. And they all have very similar looks. And this is the group, the myositis group, is really the ones that you see the straight edge side of. And that's this line across with profound volume loss. I mean, right? If you're thinking about what branches these are of the lung, these are probably, you know, segmentals, and they're almost getting to the pleura. Right? So you have profound volume loss down there. Anterior lung sign. This is one of the best examples that I have, where they have both exuberant honeycombing and beautiful anterior lung sign. Similar somewhat to the one that they show in the APS one, but almost wedge-shaped focal fibrosis. And actually I have a case like this that's also emphysema. So the fact that it's fibrosis is it's almost more the fact that it's the pattern of four corners or anterior lung that tells you that it's connective tissue disease as opposed to the fibrosis itself. So fibrosis and emphysema are just ways that the lung deals with an insult, and there's a lot of overlap in those. So this is the sagittal of that same image, of that same patient, and a wedge-shaped anterior lung. And they probably would have been a four-corner sign, except now their fibrosis is so extensive that it's just taking up the entire lower lung. Also notice how much involvement there is, but how little volume loss there is. Right? This is really a characteristic of that exuberant honeycomb. For the four-corner sign, this was actually the first case that I looked at. And it's not very impressive, but it was one, this was a tripler. And I just thought it was funny. It just struck me as funny. I had focal fibrosis I didn't catch it right here, but in these three areas, and it was there as well. And I thought, that's just a funny pattern to me. I wonder why. And I hadn't read anything about it. And mixed connective tissue disease actually is not an uncommon one to have this four-corner sign. This is one of the best examples. I think this is from our scleroderma cohort. A very focal fibrosis in the anterior lungs. It doesn't always have to be on a single image. You can be on a higher image and see the upper lobes and then get down to the superior segments and then see it there. But this, occasionally you will have it all on a single image like this. And this is just a no-brainer example of connective tissue disease. And so even if I had a greater fibrosis at the lung base, which actually this patient has a fair amount of fibrosis here, but if I had something that was more impressive, that was a gradient, you could say, oh, that's a UIP pattern because I've got a basilar gradient of fibrosis and all that. But there's no way I would put it into a UIP category because, or a probable UIP category because of the four corner sign. So I'll even get away from the categories themselves and just say, this is a pattern suggesting a connective tissue disease. So if you've ever seen, for anybody that's seen any of my medical student lectures, I always have this image in there. This is Plato's allegory of the cave, Socrates, right? And this is truth and how he's thinking about truth. And we're all these, we're chained down, right, in the cave on the ground. And behind us is a fire, and it's casting this light. And then there is something that is a real bird outside flying around. But inside this cave, all there is this puppet of a bird that somebody is moving around and casting a shadow. And that's our interpretation of reality. Right? This is the truth, as far as we understand it. And radiology, right, is such a perfect example of that, where shadows cast, and we're trying to tell what the truth is, and there's this truth that we don't fully understand, and nobody does, right? The patient doesn't fully understand it, the physician doesn't, whatever. But not only in radiology, in terms of this kind of perfect example, this is also true of medical literature. An example of that is diffuse pulmonary ossification. So I'll show you some examples of what that is. But this article came out, this is Egashira, I think it was 2017. It's hard to see here, I have to zoom in, but it was primarily, even though Egashira is from Japan, the group was primarily the Brompton from London. And they put this article out that said DPO is common in patients with fibrosing ILD and is significantly more prevalent and might be useful in differentiating DPO from IPF. And reading this article, I immediately knew it's not true. This is not true. I see fibrosis all the time, and I see DPO and connective tissue diseases all the time. And so then the question is, how do you make something true statistically that is not true? So then you go into the materials and methods, and you find this little sentence. And I think this is a cautionary tale for interstitial lung disease, that I can create cohorts that prove whatever I want to prove in interstitial lung disease. So you have to be very careful in how you build the cohorts, and I do everything I can not to see any images before I build a cohort, because that it's going to skew the results. And this is the sentence from which further exclusions were made, which is detailed in Appendix E1. So now you have to go find Appendix E1, which is only online, right? So then you find Appendix 1. And actually in the middle of this, I was writing the guy, Jacob, from Brompton, telling him, this isn't true. And he said, well, it's really chronic HP. We recognize that it wasn't as common in chronic HP, and that's what we were really showing. But that's not really what they said, right? And what they did was they removed all the patients that had chronic HP or connective tissue disease that had a UIP pattern. So it doesn't differentiate anybody, right? Because all the ones that you'd be confused about, which are UIP patterns that are not IPF, they removed, right? So the building of the study made it completely not true. So what is diffuse pulmonary ossification? All it is bone formation inside the lung, but you see it as these little calcifications in the areas. There are idiopathic forms of DPO, so occasionally you'll see these patients that have these very fine calcifications, primarily in the interstitial distribution, basilar predominant, and they don't have a lot of fibrosis. And those are rare. They're idiopathic DPO. Some people believe it's related to recurrent aspiration. But far and away, the patients that you'll see them in are fibrosis patients. And I don't know if this is projecting very well, but these areas of fibrosis along the back have calcification in them. And just to help out with that, I put it into a soft tissue window here. See if we can you see any of these?
Yeah.
Right? So they're just little punctate calcifications throughout the fibrosis. They were originally described as, there are two forms, nodular, and the reason I tell you this is because it's confusing. The terminology is confusing. It was originally described as nodular pulmonary ossification and dendriform pulmonary ossification, and it was a diagnosis by pathologists, right? And the nodular was the most common, and it was secondary to mitral stenosis. But we don't see mitral stenosis anymore, right? Because we replaced the valve. So we don't see those patients anymore. So we don't really have a lot of nodular pulmonary ossification. Most of this probably really is, if we were to biopsy these patients, dendriform pulmonary ossification. But then people started using the term diffuse pulmonary ossification, and now it's unclear, because a pathologist now thinks that they're talking about dendriform, this DPO. And so just to get away from all of it, I just call it pulmonary ossification. Pulmonary ossification, and it's I'll explain why it's not helpful. So can DPO distinguish IPF from other causes of fibrosis and interstitial pneumonia? And the answer is no. So we did this study. So as soon as he told me, well, it's chronic HP, then the study was clear in my mind what that would be. That would be IPF, scleroderma, which I knew I saw this all the time in scleroderma, probably because they really developed that one and rheumatoid arthritis are the most common to cause a UIP pattern. But scleroderma tends to be a little bit more similar to IPF than, so anyway, I just knew that it would have these calcifications. And so it was true what they thought, which was chronic HP has a less prevalence of DPO or pulmonary ossification than the other ones. Is it a useful distinguisher? No, right? I mean, this is 8 out of 42 versus 12 out of 42. So that, in practice, that's not going to be a useful finding. There is kind of the negative bias of publication, right? So I initially tried to work with Egashira on it and couldn't make it happen, and you can't get this published in radiology. Like this study doesn't get published in radiology because it's a nothing, right? And you're saying this does not help, right? So it's a negative bias. So moving on to NSIP-OP. This is one of my favorite patterns, and it's one of the most useful ones, and why I tell the residents, you have to look at every single chest CT the patient has ever had. If they're coming in for an interstitial lung disease and they have 20 chest CTs, you have to look at every single one of them. And it's because of this type of behavior. So myositis syndromes, like I said, dermatomyositis, polymyositis, and antisynthetase syndrome commonly produce this mixed NSIP-OP pattern. And I'll show you examples of it. The only other thing that really does this is drug reaction. And it's got a different pattern to it. If you were to biopsy them, they would say, yes, this is mixed NSIP-OP, but they look different. So those are really the only two groups that develop NSIP-OP. And maybe you could say COVID looks like it. I mean, we've all had the best training ever in history on what organizing pneumonia looks like, because we've all read so many examples of organizing pneumonia with COVID. And maybe in the evolution of COVID, it might have some overlap with this pattern. But we're just not seeing that anymore. Thank goodness. Another example, so I'm going to kind of march through the years. And it's funny, there was never kind of any landmark article on this that just showed, hey, NSIP-OP is just excellent at differentiating myositis syndrome. So that's another study that could be done. This one's 2021. This one only showed 9% in that subgroup. But I wanted to stress the point that 55% of these patients from myositis only had ILD, right? And this is also a common thing that I see in this pattern, is that when I see this in a patient that's just presenting, it's not uncommon, half the time, not really half the time, maybe a third of the time, that they don't have any other diagnosis to them. So saying this pattern is very characteristic of a myositis syndrome will push them into getting the right sets of labs, which are really the anti-synthetase labs, which are really the ones that show this, whether it's anti-Joe. There's a long list, and it keeps growing. Third one, 2023, this is the most recent, and just that this particular pattern was also associated with progression of the disease as well. So it's useful as a prognosticator as well in this subgroup. But I'm going to show you some examples here. So this is mixed NSIP, 66-year-old shortness of breath with anti-OJ antibody. But they had no systemic symptoms. So let's go through this again. So very basilar predominant, a lot of volume loss, and it's got features of both NSIP and OP. So it's got consolidation to it. It's going to have areas of ground glass, and in those areas of ground glass, you're going to have architectural distortion, septal thickening, and reticulation, right? And that's the combination you're looking for. Organizing pneumonia already causes that architectural distortion. It'll speculate a little bit on the periphery sometimes, that kind of thing. But that combination of those two things, basilar predominance, you can tell them this is myositis syndrome. And then you'll periodic. But most of the time you'll wow them. This one is, I wanted to include this. This is a 31-year-old anti-Joe myositis symptoms. But this pattern begins to look a little bit more like drug reaction, where I would look at this and say, I've got patchy, ground glass, it's all over the place. Some of these have very classic atoll sign look to them, so I know it's organizing pneumonia. But as I come down to the bases, this is really classic looking. So I've got features that tell me it's organizing pneumonia, but then I've got this basilar predominant look that looks really like NSIP, and so this is combined NSIP looking. And then just a still image of one of the more impressive examples. And actually in this patient, this was a very interesting patient that we had. It was a myositis, or anti-synthetase. And we were doing a PE study because a lot of these patients, fluctuate. They have kind of a acute worsening of symptoms, and so you end up getting a rule-out PE study on them, CT angiography. And this one, they had this really bad fibrosis in the lung bases, but the vasculature didn't fill in, and so you couldn't tell if they had a PE or not. All the normal lung filled in just fine. So then we kept them on the table and did a dynamic and showed, this was a different article that we put out, that you could do a dynamic and show that these areas of fibrosis filled in with time. What we didn't know is if they were backfilling from the systemics or if they were still just slow filling from a very kind of lag type of passage of blood flow through the lungs. But this is very profound, basilar predominant, right next to unaffected lung. Some areas that are consolidative, that are clearly organizing pneumonia, so very NSIP looking at the bases. And then this has a very classic example, straight edge sign, which this patient, we already kind of knew that they would be myositis, but the straight edge sign is where you see these patients. So that's the NSIP OP. So we've gone through the signs, we've gone through DPO, we've gone through NSIP OP, and now I just want to briefly talk about IPAF, interstitial pneumonia with autoimmune features. The reason that this is important is that there's a subgroup of patients that just do not meet criteria by rheumatologic standards to put them into something, but they they have a flavor of connective tissue disease or autoimmune disease. There's a lot of names that have been used for this, lung-dominant connective tissue disease, undifferentiated. And this is probably what you'll see the most often as a use, undifferentiated connective tissue disease. But it gets a little long when you add associated ILD, autoimmune feature ILD. And in the rheumatologic literature that I've seen, they still kind of look at this as, no, this is kind of a research term or whatever, but I think this is really the catch-all term. And a lot of these patients will then move into a full presentation of their autoimmune disease. So 14% of patients with ILD in rheumatology clinics do not fulfill classification for a specific rheumatic disease. So if they've got interstitial lung disease, this 14% is IPAP. 15% who present with ILD later prove to have a connective tissue disease. And this is really the most important one, because in that Panther study I talked about, there was a subgroup in that Panther study, and those patients didn't progress. Everybody else that was IPF, they got worse and they died, but there was a subgroup that just kept trucking along, and they were rheumatoid arthritis. They ended up proving themselves to be RA, because it looks so much like a UIP pattern in those patients. And then one of the other reasons that I encourage people to look at every single chest CT is that NSIP can evolve into a UIP pattern. So that the challenge of looking at a chart and saying, oh, this patient meets criteria for a UIP pattern, next case, 10 years ago, they might have had an NSIP pattern. And it doesn't matter to me that they have a UIP pattern now. And so in those cases, I'll say, this study is currently a UIP pattern, but over time has proven itself to be a connective tissue disease. So that was just kind of short thing on IPAF. And so then you're familiar with that term if you hear it from now in terms of an ILD. Distinguishing CTD-ILD from post-COVID ILD. So I don't know, you've probably seen a fair number if you're reading chest CTs of these cases coming across, and they've got this very well-defined subpleural line and as a residual of the fibrosis. And what the studies have shown that have looked at this kind of 6 months and 12 months out is if you have a moderate to diffuse lung disease, there's 5% of that group that will still have some element of what they're calling fibrosis-like changes. And they don't call it fibrosis because nobody's biopsying these patients. So we can't say definitively this is fibrosis, but maybe 5 years from now we'll be comfortable calling it fibrosis because it never went away. But we are seeing that they progressively improve, right? And so then what's left behind often is this very thin band of fibrosis in the periphery of the lung that if you were to describe it 10 years ago, you would have said this is subpleural sparing and this is a connective tissue disease. But now, we don't say that, right? So they will slowly resolve over time, only a small subset. This one was 1 year out, and it was only 5% that had continuing fibrosis. And my sense on these is that we're still seeing a fair number of these patients come across that are significantly symptomatic, and that's out of proportion with what I'm seeing on the CT. So to me, that kind of fits more with what we saw with post-deployment lung disease, where these patients were coming back, and we couldn't see it at all. And it was a classic history, right? They could do their push-ups and their sit-ups, but they couldn't pass the run. And they previously could before deployment. And about 58% of them would have smoke exposure, from the burn pits, but it was only 50%. But the take-home on that is we couldn't see it, and it wasn't until pathology took out pieces of lung that they called it they thought initially it looked like, they called it obliterative bronchiolitis. When we looked at that same cohort at National Jewish, it was somewhere between HP and obliterative bronchiolitis. So it's something of its own entity, but a very nice, comparison for this, where they've probably got something going on that we can't see on CT. And whether that's a vascular abnormality or gas exchange, we don't really know. This specific article, and several of them talk about subpleural line. They're very careful to use this term so that they don't use subpleural sparing, because subpleural sparing would imply connective tissue disease, and it's in our little, it's one of the categories in our original ATS criteria for UIP. So they're very careful not to use that term. Again, another case where they talked about this subpleural line. They're primarily case series. So what we did was we said, okay, well, let's take every study that someone has said subpleural line or subpleural sparing and see if the subpleural distance will differentiate these two groups, because that was our observation, was that the space between the subpleural line and the pleura was greater than we see in SIP. In SIP, it's like 3 millimeters. In post-COVID ILD, it's about 10 millimeters. And that's what we saw, right? So when we took all these patients, we had 44 non-COVID, and this is a really difficult cohort to build. This non-COVID ILD that has subpleural sparing that's been called on imaging by somebody. And then, so 44 was as high as we could get with that. When we used the same criteria, it pulled 35 post-COVID ILD. I think we could build that number greater. But when we looked at the two, I had a medical student and a pulmonology fellow do these measurements, right? And this is a tough measurement to make, actually. If you're scrolling through a fibrosis case and picking a specific spot that we said, we called it the dominant arc of disease. So they had to pick a dominant arc, and then often those dominant arcs are kind of varying in their distance from the pleura. So then we told them, pick the middle of the dominant arc and measure it. And their agreement was surprisingly good. In their inter-rater agreement in post-COVID ILD was 0.8. That's really high. So it's an easy measurement with the subpleural line. It's a more difficult measurement with an SIP, and their agreement there was 0.3. So that was a little tougher. But even with that, we showed that it was significantly different between the two subgroups. But it was not statistically significant for us to be able to put a specific value on it. We couldn't say, at 10 millimeters, this is post-COVID. But I will tell you, at 10 millimeters and above, it's very likely to be a post-COVID residual fibrosis. The overall inter-rater agreement was 0.55. So this is what I'm talking about. This is classic NSIP subpleural sparing. It's the reticulation comes down. There's a little bit that will cross the space, but it's got this subpleural sparing, much different than what we see in a UIP peripheral fibrosis, where here the dominant arc is like this. And you can see that would be that's not always straightforward. And then this side, which side is that? I was surprised at how well they did with it, and how much consistency they really had in their measurements. And so my last slide, that I just wanted to say how happy I am that people are getting back together like this and having meetings, and that it's good, like it's good for us as a profession, especially to come together as across groups, and for the greater good that we recognize that sharing like this is good for patients, and so hopefully you saw in this presentation the good, the true, and the beautiful. Thank you. Any questions about anything?
So if we've got, say, a series of 2 to 4 scans over a couple of years, if one of them appears to get better, visibly better, and then maybe comes back a little more substantial appearance of connective tissue disease, does that mean it's non-fibrotic and therefore not part of this spectrum, or does it make a difference?
Okay, so it depends on what you mean by gets better. Because in the connective tissue disease, I will say it is very characteristic to have organizing pneumonia goes away. Combine an SIP, OP goes away. Now it looks a little bit like an SIP. Then it's progressed, and now it's reached a point of being probable UIP pattern. Like I've seen that. So that, if that's what you mean, then yes, that's characteristic. If you mean that it totally goes away.
In other words, is the organized pneumonia and the NSIP, they're kind of separate processes in a sense that move in different ways.
Yep. Yeah, so certainly, they can come and go. I will say, though, with that, I am surprised at how much will resolve out of organized pneumonia, or even post-infectious. I've had some cases where I thought, this viral disease is going to have fibrosis, and it just will completely go away. So when I've got significant aerospace disease associated with that architectural distortion, I'm very careful not to overcall fibrosis in those patients, to say, get a follow-up and we'll see where it's at. Does that answer your question?
Yeah, I think I understand.
Okay.
At what point do people get biopsied?
Usually when they progress despite treatment. So that's, even if you have, okay, so I should caveat that. That's for the CTD-ILDs. For, wait, it was biopsy, right?
Yeah.
Yeah, I'll just leave it at that. I was thinking of a different one. But yeah, so in the connective tissue diseases, basically when you don't have a clear diagnosis, but they're continuing to progress despite what you think they have. It's become very difficult because all of those are like indeterminate pattern, and you feel useless in conferences because you're just like, this is an indeterminate pattern. The one subgroup in that is, well, two. If they haven't looked at the really remote exams and I catch a CTD-ILD that way, that'll be one where we catch it. And the other is HP. People underestimate how good mosaic attenuation really is at differentiating HP. And so they'll still think it's IPF, but no, this is HP. And 50% of HP doesn't have an identifiable antigen. So,
you show several examples of cases where there was some bias in medical literature. It wasn't set up correctly. So you kind of have been around a long time. Have you seen a trend in this? I mean, has it always been that way? That there's, you got to look carefully at the literature, to look at the cohorts, or is there a trend in that you've seen?
Well, I think what was really most impressive to me here was that it was radiology. It was the Journal of Radiology. So, I mean, that they really have very strict oversight and peer review. I'm super cautious of anything that's coming, from all these other side journals.
Yeah, because there's so many of them.
Yeah, it's just so much.
There's an explosion of stuff.
Yeah, I'm careful even with the case reports or any of that. I'm cautious. One example that we had that was so there was a kind of a camp that loved breast shields, right? And there was literature on the breast shields, and I was reading this, and it said that it increased their likelihood of breast cancer by some significant amount. And I looked at that and I said, there's just no chance that's true. So the data that they were referring to was this epidemiologist from the NIH, his last name was Conrad. So I wrote him and I said, hey, does this information look consistent with the studies that you did? Because he did the studies for Hiroshima and Nagasaki, mixing them. But and he was like, no, that's not at all. They were orders of magnitude wrong. They were wrong about the population, the subpopulation of who would develop the breast cancers. So it was just completely wrong. And I ended up writing a letter about that. So, yay for not having breast shields on all our chests.
Yeah. Dumb question. So, when it comes to the management, you're talking about like drugs, biopsies. On the front line, who tends to be leading the chart? Is that more like pulmonology? Is it rheumatology? Like, who tends to be?
That's pretty variable because of how they're presenting. We had a rheumatologist. Did she step out? Yeah. It's really what symptom are they presenting with, right? Unless they're presenting to the ER and they happen to get a PE study or something.
Like
But, exactly. Stroke protocol. But yeah, so it's really driven by what their initial symptoms are, which can be very misleading, right? So if they are just coming in with shortness of breath and they haven't manifested their myositis or whatever it is, then they haven't seen rheumatology and they probably haven't had any type of rheumatologic workup. And often that won't happen until they hit pulmonology. And then the pulmonology will get the panel and then begin to cascade. But I think we can be very useful in that, in saying this pattern is very suggestive, so that even if they get negative results back, they might still refer to rheumatology for ongoing follow-up. And there are things like antisynthetase has very characteristic mechanic hands, and I don't know that every pulmonologist knows that about mechanics hands.
Just one question. I may have misunderstood what you said, but on your paper with signs, when you have exuberant honeycombing with that sharp edge on the coronal view, did you classify that as straight edge and exuberant honeycombing or just exuberant honeycombing?
Yeah, only if on the coronal it created this line of involvement that really involved the entire base of the lung. The fact that there's a line there is, in a way, what we're describing in exuberant honeycombing, because we say 70%. If it's 100%, then you're going to get this perfect line right between the involvement and the honeycombing. So in a way it's that, but it's probably, if AI were to recognize this, it would have probably been the well-defined differentiation between the two. I think that's all we're doing, is we're just kind of doing the precursors to what AI is going to differentiate later on. All right. Thank you so much for letting me speak.